from the recent large studies like Apollo or hATTR, it appeared that in many patients there was not only a neuropathy, but also a very significant cardiomyopathy. And it can be observed in the V122I mutation, as it's classically reported, but also in V30MET early onset or late onset, and finally in more or less all mutations. The frequency of cardiomyopathy probably depends on the type of deposits and on the length of evolution of the disease. And for instance, now we've seen survival, prolonged survival with patients with the early onset V30MET, and now we can see cardiac disease, very severe cardiac disease happening later on. In most of studies, the definition of cardiac involvement is limited to increased left ventricular septal thickness over 12 millimeters. And with this very simple definition, what appears in Apollo or in hATTR is that mixed phenotypes are observed in more than half of patients. So what's the importance of this? Well, as you can see on this slide, it's been described for a while now that any phenotype that includes cardiac disease has a worse prognosis than patients with only neuropathy. So this is from the very start important to determine if the patients have any cardiac involvement. You can predict this more or less by the phenotype of the patient. For instance, patients with early onset V30MET, the classical neuropathic phenotype, those patients have rare cardiac involvement, delayed cardiac involvement. Well, this is the general picture, but you have to be very careful of variation within the same family, sometimes unpredictable. So you should check the heart even in those patients. For it's more classical among a patient with late onset after 50 years, be it V30MET or non-V30MET, those patients have very often a mixed phenotype, and those have a higher incidence of cardiac and ophthalmic involvement, even though they have also a neuropathy. And even in the ILE122 mutations with a so-called cardiac phenotype, well, if you look carefully enough, you will find some signs of neuropathy in about 10% of those patients. So the type of mutation you are dealing with in the place you work might influence your judgment. For instance, if you are working in the Mayo Clinic, you will see 26% of T68, so that's the English mutation, 15% of V30MET. If you are among the TEOS group, you will see 73% of V30MET and only 2% of the T68. What we see in our group, this is in Paris, and this is more than 200 patients, it's about 60% of early onset V30MET, 20% late onset V30MET, and the rest are various mutations. As Teresa showed previously, it is very important to detect the disease onset while patients are still asymptomatic, or when there are really minor symptoms, because at that stage it will be probably easier to stop the disease or even obtain some degree of regression. But if you wait too much, it's going to be too late. So the first challenge is to make a diagnosis, timely diagnosis, and try to get, I'm sorry, I lost my mouse, and to get to the diagnosis early so you can start the treatment early. So for this, you have to look for minor signs and symptoms and be very careful when you follow patients within a family with a carrier status that is established. When you are getting close to the predicted age of disease onset, as you can determine it by the family history. And from that time, if you get any signs or symptoms of onset of disease, you will have to give those patients a treatment as early as possible to avoid a bad evolution. So considering the heart, what are the targets? Well, historically, the very first target that has been identified is conduction abnormalities, arrhythmias, cardiac arrhythmias, and possible sudden death. As a matter of fact, the real frequency of sudden death in this disease, in hATTR, is not very clear. What we have seen is in patient who died within the cardiology department is electrical dissociation and nearly ventricular fibrillation. So what we are confronted with the most of the time is heart and atrial fibrillation. The second type of involvement is infiltrative cardiomyopathy, which can be diagnosed by echo, cardiac scintigraphy, by MRI, by NT-proBNP and biomarkers. And finally, the most frequent but the less easy to determine is cardiac denervation. So how do we approach those patients clinically? Well, first there are just the usual assessment of those patients, looking for shortness of breath, try to determine their NYHA class, although neuropathy can come in the way and make it impossible. Assess the dose of diuretics that those patients might require to feel comfortable. This has been recently reported as a very good tool for following patients with cardiomyopathy. The frequency of syncope, of the comorbidities, and most of the time, it's when those patients had hypertension, their hypertension disappears, and this is a sign of progression of onset. The resting heart rate, if it's possible, also the 6-minute walk test, and it is important to assess the limitation, the heart rate response to exercise, and so we can this way check for chronotropic incompetence. Also to assess orthostatic hypotension, which is a marker of denervation. So apart from this clinical assessment, which is of major importance, what are the other tools that we have? The ECG will show in typical cases of cardiac infiltration, microvoltage, and which is mostly important when there's a discrepancy between ECG and LV hypertrophy or pseudo hypertrophy by echo, but also bundle branch block, AV block, or pacemaker previously inserted, or arrhythmias. So first, it's easy, check the ECG of those patients. Second is serum cardiac biomarker, and mostly NT-proBNP, which is very sensitive and which will give you here the heart function. It's quite simple and it's quite interesting to repeat. Troponin, increase of troponin is mostly observed in severe forms. Echo is the cornerstone of the assessment. It will show you LV, which can be measured very precisely, but also diastolic function, dilation of the left ventricle during systole, and valve thickening. It is very important that this examination be repeated by the same as possible on the same machine in order to make sure that differences are meaningful. But you have to keep in mind anyway that the inter-observer and intra-observer repeatability is not perfect, like for any kind of non-invasive technique. So echo has limitations also. Bone scintigraphy imaging is very useful now because it will give you a very clear answer. If you see an hypertrophic cardiomyopathy, is this amyloidosis? Bone scintigraphy will give you a specific and sensible answer. But once again, it cannot be repeated because it does not have the spatial definition that could make it useful. CMRI will give you very refined information, some of which are redundant with echo, some are more specific, like T1 mapping or measurement of extracellular volume. And finally, in the end, cardiac biopsy is very rarely performed nowadays because we can get to the diagnosis and follow patients without invasive procedures. So which test and investigation should be used at baseline? Those tests, whatever you are going to use, should be targeted by clinical assessment. The 6-minute walk test. You have to bear in mind the phenotypic presentation regarding the specific TTR variant that your patient has and the age difference with pedo. And as you can see, in all cases, ECG, biomarker, and echo will be useful. DPD scintigraphy will be also useful, maybe except in early onset V30 MET, but in all the other cases, it's very useful to have a baseline recording because sometimes you will find very early positive. MRI is also very useful. During follow-up of the patients, well, clearly you will have to do a clinical assessment. You will have to bear in mind the age difference with pedo. You will have to repeat the same examinations, but clearly not scintigraphy if it was previously positive. You will, and not negative as written here, you will get help from suspected progression as defined by biomarkers or echo.